I would like to express my gratitude to the organizers and Professor Vasilios Kotsis for inviting me one more year at this outstanding meeting, even that in the last 2 years are not presential. That is a pity. Well, then I will try to share my screen first. Okay, then this is my first slide. Okay, that's it's available in the screens, the slides. Okay, then, well, my task today is to speak about resistant hypertension, some aspects related to the diagnosis and management. The first that I would like to say always is the definition. Definition sometimes is just confused, but the most used is that when a therapeutic plan that has included attention to lifestyle measures and the prescription of at least 3 drugs in adequate dose, 1 diuretic, has failed to lower systolic and diastolic sufficiently. This is clear that sometimes is also used when a patient needed 4 drugs to be controlled. It is clear and very well known for many years that resistant hypertension is a very high-risk condition. This is a data from our series in the 90s, in that you will see here in patients with refractory hypertension, what is the probability of event-free survival. That in the first decade of the next century, that's in our clinic, we have better results in this. For sure that the treatments applied are much more established, and then it seems to be that we learn something on how to treat this kind of patients. But the clear is that still even a very high risk for that events. But what really is resistant hypertension? Resistant hypertension have a complex pathogenesis that there are many factors that influences. You will see this chart in which you will see around the center, there are many factors that can influence. But at the end, this convey in 3-4 aspects. One is an overload of sodium and volume, or an increment of sympathetic nervous system, or and vascular dysfunction. Vascular, well, in arterial stiffness, or in the microvascular with endothelial dysfunction. With this insight, in my talk, I am going to speak about 3 points. The first is 5 steps to evaluate resistant hypertension. The second one is the pharmacological approach, and I will also touch in non-pharmacological approach. Considering the 5 steps to evaluate, we need to confirm true resistance. We need to identify what are the frequent causes which maintain blood pressure high, and will be easy to take out. The third is to assess the underlying organ damage of the patients when we evaluated the patient with resistant hypertension. The fourth is, of course, rolled out secondary causes of hypertension and evaluated the potential impact of it in the treatment. And finally, we need to try to identify what are the predominant mechanisms for resistance to blood pressure control. To begin with the first, confirm true resistance, there are 2 main things to do. One is to use out-of-office blood pressure, and then ambulatory blood pressure monitoring. For sure, it's the tool that we need to use. This is one study. This is the first study that demonstrated the prognostic value of ambulatory blood pressure in refractory hypertension that our group published many years ago. And in this, we identify how the tertiles of ambulatory blood pressure values are of prognostic value. Those subjects with the lowest tertile have the lowest risk for that have events, cardiovascular events. More recently, we perform and conduct one study in which not only measure one time the ambulatory blood pressure monitoring, we use that repeated measurements of ambulatory blood pressure monitoring, and in a cost-derived of time, in 382 subjects, you will see how the average of 24-hour systolic blood pressure, less than 135 millimeters of mercury, are those that have significantly lower risk than those that have higher levels. In other words, it's important not only to assess at the time of the diagnosis, we need also to control and to see what happened during the follow-up using out-of-office blood pressure. But the main cause for, at the time, to confirm true resistance is the adherence of treatment. Before it has been speak about adherence of antihypertensive treatment and other things, but this has studies that assess the adherence in subjects with refractory hypertension. But this was assessed measuring in plasma and in urine drug concentration. And as you will see, in these 9 studies, the majority of them have are partial non-adherent. This means that at least one of the drugs that theoretically are taking the patients are not in the blood or in the urine of the patient. And there is not a small amount, a small percentage of the total non-adherence of treatment. Then to check adherence of treatment is a very, very relevant issue. The second, and this non-adherence for sure, is related not only with the antihypertensive treatment, it is also related with the number of drugs that the patients are taking for other conditions. And then the highest the number of drugs, the higher the percent of adherence. In 2 countries, this is Czech Republic and this is in UK, and this similar for men and women. Even that decreases over the years. In the older people, whatever the case, still in the older people, still also a situation of non-adherence to treatment. The second is to identify frequent causes of fall resistance. One of the first that we need to ask the patients if there's a snore. We need to try to identify if the patient will have sleep apnea, because sleep apnea is one condition that can maintain the resistance. Of course, look for using pressure drugs, non-steroid anti-inflammatory drugs, corticoids, vasoconstrictor nasal drops, and recreational drugs like cocaine. We also to try to identify if the patient is gaining weight or if they have severe obesity. There is the main cause of the refractarity to treatment. Also, we need to exclude intake of heavy intake of alcohol or other recreational drugs. And finally, one important thing is the salt consumption. Salt consumption is one condition that maintain that a high volume in the patients, and then it's a facilitate that the blood pressure is high and then will be resistant to treatment. The third aspect is assessing organ damage. For what? Of course, first of all, is to identify if the patient is a very high-risk subject. On top of the high levels of blood pressure, the patient have organ damage. But it is also useful as a reference for assessing for the treatment success. We will use, if we have a left ventricular hypertrophy, increment of urinary albumin excretion, we need to check during the treatment of these patients in order to see if there are some kind of regression. And the minimum required for sure is to assess left ventricle, urinary albumin excretion, of course, the glomerular filtration rate, and if available, arterial stiffness can be used, but even in my opinion, is not as much or as important like the left ventricle mass and the urinary albumin excretion. The fourth, for sure, is to rule out secondary hypertension. Mainly, the most frequent is hyperaldosteronism. And very easy, you can assess aldosterone and plasma renin activity in conditions you can maintain drugs. The only drugs that you need to take out at the time to assess this ratio is beta blockers, because reduce the activation of the renin-angiotensin system, and anti-aldosterone drugs. Even you can check if the patient is taking drugs that block the renin-angiotensin system, because it's one way to stimulate the system, and if it's blocked, for sure, it's more impositive that the patient will have an hyperaldosteronism. And finally, is to try to identify if the patient have a volume overload, a sympathetic overactivity, have mainly structural vascular changes that are maintaining this high blood pressure. For sure that there is not only one of mechanisms, there are mixed, but always one of the mechanisms is the predominant. And to suspect one or other, for example, if you are, you can suspect the structural vascular changes if it's a hypertensive long-term that has not been treated. If the patient has severe atherosclerosis, or in patients that have a very high pulse wave velocity. If you are, or you can suspect about volume overload, if the patient has inadequate diuretic therapy, if the patient have high sodium intake, if the patient has a sleep apnea syndrome, because sleep apnea syndrome is one of the conditions in which is an hyperaldosteronism, and there is a central overload of volume. Of course, the presence of hyperaldosteronism, and also if we have a progressive worsening of renal function, then volume overload need to be considered. Suspicion of sympathetic nervous system overactivity. Well, one patient with elevated heart rate in resting conditions, with a very high blood pressure elevation at arousal in the morning. But if you want to apprise very well this, you need to use more sophisticated techniques. Then, how to manage these patients? First, with drugs. Everybody knows what are the drugs that have an additive effects and also control side effects. I don't go to touching this because everybody knows in this. But I think that there are some questions that we can start to answer. The first is a step-by-step approach takes time. It is better an early introduction of triple combination. This needs to be considered from the beginning in patients with stage 2 hypertension. Concerning the diuretic treatment, is diuretic treatment insufficient? 12.5 or 25 hydrochlorothiazide is enough? Maybe chlortalidone instead of hydrochlorothiazide, more potent, and the distribution medication around the clock. Then you need to think, if you are giving 3-4 drugs, to move one drug at bedtime will be okay or not. These are questions that can be above the table when we are trying to start treatment and to control patients with refractory hypertension. And we arrive to the fourth drug. What is the best fourth drug? Well, the pathway to a study demonstrated years ago that the best drug to use is spironolactone. But spironolactone is not contraindicated if the patient have a glomerular filtration rate below 45 milliliters per minute, or it have potassium levels higher than 4.8 milliequivalents. Whatever the case, even that there are not these two conditions, you start a spironolactone in these patients, you need to monitor creatinine and potassium shortly after the introduction of the drug. But of course, it's the best drug if it's possible to give that. If no, we can use bisoprolol, doxazoxime. Okay, these are other possibilities that you will have. But what are the new things that we can do that are not included in the guidelines? We have two kind of drugs that are marketed today that can help us to control resistant hypertension. One is sacubitril valsartan. The neprilysin inhibitor increases the impact in reduction in blood pressure. This is against placebo. When you are giving as compared to other treatment with more dose of ARBs, there are an additional effect. Then you need to consider, and if the patients have that some stage 2, 3 of heart failure, to consider sacubitril valsartan as an additional drug in order to treat. The second one is sodium glucose cotransporter inhibitors. These have several mechanisms to reduce blood pressure directly, but at the same time produce some effects, reducing that sympathetic nervous system activity, oxidative stress and inflammation, and then, of course, protect the kidney at the same time. And it is very well known that the addition, in this case of empagliflozin, to treatments with ACE inhibitors of ARB produce an additional reduction in blood pressure. And then we need to consider. But right now, we have 2 drugs that are in the period of clinical trials before to achieve. The first is the aprocitentan. Aprocitentan is an orally active dual endothelin receptor antagonist that is effective reducing drugs over triple treatment. We have in a clinical trial in the last 2 years, and looks like that works very well, and it is perfectly tolerated. Don't have the problems of the anti-endothelin blockers that we had used in the past. And there is another one with a more sophisticated mechanism of action. It is the fidivastat. Fidivastat is a blocker of aminopeptidase A in the brain that reduce angiotensin III generation with this a decrease in the renin-angiotensin system, sympathetic overactivity, and also in decrease the secretion of vasopressin. Then this is a drug that we are also in a trial of this that is used in this case in this trial. We use it in one trial that practically is finished, and we are starting another one in which this is added to, and patients with one in refractory hypertension, another in lack of control after 2 drugs. Then these are possibilities that we have in front of us, the new drugs, new mechanisms, and seems to be really promising in order to have tools in order to help us to control refractory hypertension. And finally, non-pharmacological approach. First of all, you are waiting for renal denervation, but the first is to reduce salt. Here, this is one trial in which you will see the impact in reducing salt. This is absolutely sometimes mandatory in order to control this patient. The second one, also classic, CPAP in patients with sleep apnea. But in patients with severe sleep apnea, not all patients with sleep apnea can get advantage of in blood pressure reduction when we are using CPAP. But in those with severe, for sure, that is useful and can help to reduce blood pressure. And we go to instrumentation. The first introduced was the renal denervation. The second one was the baroreceptor stimulation. And the first one that I think is not promising is to reduce arteriolar resistance, producing a bypass in between the vein and the artery, iliac or femoral, mainly iliac. Because then you reduce resistance, but you produce one circulatory hyperkinetic that at the end will be not best for the heart. What about renal denervation? Well, all of you know the history. I go just only to say some words. Well, you know what all the series of the simplicity that was seems to be effective for sure, but this that was the initial promise when a proof of concept studies came the down in the idea with the simplicity hypertension 3, because you remember that don't demonstrated efficacy in that. Well, this trial was criticized in many aspects, but well, and appears new ones that has been used in patients without treatment, just only denervation, or with one treatment on taking out treatment. Or the last one that was published recently in Lancet, you will see here the Radiance hypertension trio on top of 3 drugs. What is the impact in the renal denervation? But the problem.
Sorry, Professor Redon, you are muted. You have muted your microphone and we cannot hear you.
Yeah,
Thank
and
you.
right now?
Yes, we're fine.
Right now? Yeah. Well, then I back to the previous slide if has not been clear. Then and this. The main question here with the renal denervation is that the variability in the response is large, is very large. And we don't have the procedures. What are the patients that are going? We don't have data to predict what are the patients that are going to respond or not. But in renal denervation, there are some other things that need to consider. But the most important one, for sure, is this, that you don't have certainly what are subjects that are going to respond. And also, the other important thing is that even that you perform the renal denervation, the number of drugs of the patients just only reduce 1, no more. There are several techniques. I don't go to speak about this for sure because I'm not expert. But what is clear is that they are trying to improve the techniques in order to be the denervation more simple. But the most important here, at the time to consider this, is that treatment need to follow, and we don't know can be happen after 2, 3, 4 years. These are the things that remain that pending to be answered. Then this is my last slide because something happened with the computer. I can't go to the conclusions, but the conclusions I think are simple. You need to approach a patient in a step-by-step wise in order to be sure that the patient is refractory and that you can't resolve the problems before to increment the number of drugs. That you need to assess the patients, the situation of the patients, with taking in account ambulatory blood pressure monitoring, and also helping to this ambulatory blood pressure monitoring whole blood pressure. And then at the time to choose the drug, you need to see if there are no contraindications. Anti-aldosterone is the first, and we are in the way to know more information, and we have more tools in order to can choose another kind of drugs that can produce less side effects and long term. Thank you very much for your attention.